I had difficulty with this title because innovation ecosystem sounds like the ecosystem for innovation itself, and that's not what we meant at all. Meant much more the way the ecosystem of the entire community can potentially be assisted or feeds back with innovation twofold. So with that, we start off with this concept of that the health of a community and its socioeconomic aspect is directly tied with the health care of that community as well, and that they feed back and forth to one another, and that hopefully, just maybe, we can do something with innovation that'll reverse that spiral. So with that, I open with my lead speaker, Dr. Jeff Cohen. Dr. Cohen and I met via Joe Macaluso, who was commenting so well in the chat box. We do read those, folks, so feel free to go ahead and chime in there. We're watching you. And Dr. Cohen is doing some amazing work in the suburban hospital system of the Allegheny Health Network, where he was, the title is challenging, where he was doing something really remarkable, taking a mothballed hospital facility and converting it into an innovation center, but also a community hub. Doctor, maybe you can just give us a brief background on why you came across this project and why you think it matters so much to the community that you're doing it in.
So good afternoon, Michael, and a shout out to my good friend Joe Macaluso. I'm a practicing urologist, and about 2015 or so, I took on the presidency of a quaternary hospital, about 550 beds. And I got to see things that I'd never seen before, called finances. And in the medical world, as a physician, I ran a multi-location practice with about 10 urologists. You see a very skewed sense of the world. When you're president of a hospital, and my budget was around $900 million, you start to see patterns. And the one thing that surgeons are very good at is recognizing patterns. We don't do well reading, but we do recognize patterns. And one of the patterns that I kept seeing was that every month, 4% of my population was taking up 15% of my resources. And when I went to see who they were, it was mostly Medicaid patients that lived immediately around the hospital. And we started looking into this problem and started some, processes to try and understand what's going on here. And this led us down a path where it changed a lot of my views. And I listened to the last discussion about the healthcare system and the inadequacies of it. I don't go down that path anymore. I go down a path that there's something about poverty that impairs the host's response to care. So what we were seeing was that in the Medicaid population, our length of stay was 50% higher for the same diseases. They had higher wound infections. The poor just did worse. And you were talking at the beginning of the session about healthcare inequities. The bottom 5% of the population in the United States has a median survival of 63 years. The top 5% is 78 years. The fundamental definition of health inequities are the processes that lead to that difference in survival. And as they pointed out, the wealth of a nation is based on the productivity of its citizenry. So why in God's name are we allowing people to die 15 years earlier? And is it related to something about the environment that's affecting the host? So this took me down a very different path, which was I accomplished what I set out to do at Allegheny. And they said, well, what are you going to do? And I said, well, I'm just going to go do what Macaluso would do and just go run my private company. And they said, well, do you have any interest in doing anything else? And I said, well, yeah. Pittsburgh went through this process of reconstructing itself after the death of steel. And one of the things early in my career I was stunned by is that what do you do with a 55-year-old steel worker? And the answer is not much. And on a productivity basis, there's not a lot for people at that point in their lives to do. So we started looking at the relationships of poverty and healthcare. And, we noticed that there were about 1,000 hospitals that closed in the United States in the last 10 years. And surprisingly, they were all in poor neighborhoods. They were poor white, they were poor black, they were poor Hispanic. And across the board, the ratio of this was never in the wealthy neighborhoods. It was always related to an economic downturn and an increase in the ratio of Medicaid. So we went back and started looking at our Medicaid population about net operating incomes that we got from taking care of the poor. Now, that's our mission. I don't know any providers in my hospital that refuse to take care of poor people. Otherwise, they wouldn't be in my hospital. So what's going on here? And what we found was that as an economic downturn occurs, you end up with more Medicaid and less commercial, and everything you make on the commercial side, you lose on the Medicaid side. So when the Medicaid volume goes up in poor neighborhoods, the hospital can't survive. And anywhere that there's a transition of the economics of the community, the hospitals are impaired, and they end up becoming either consolidated into larger providers or end up closing. So the question then becomes is, what do you do with a closed hospital? And everybody's saying, well, you can do it for nursing homes. We had a nursing home in this hospital. The hospital started about the 1870s, and I was on staff on it when I first came to Pittsburgh. And it closed as a hospital in 2010. The community it's in was a bedroom community of Pittsburgh, about 6 miles above my hospital. And it was a support hospital for the steel industry. And as steel in Western Pennsylvania went down, poverty went up in this town and the hospital began to fail. The people that could afford to move to nicer areas, the people that were left there were poor. They were poor white, they were poor black, they were poor Hispanic, they were poor. And then we started looking at charges. The charge structure for the population was much higher than pro rata for the commercial population. So it led us back to the same place. What do you do with a closed hospital? So we decided to do two things. So we call this an experiment in disruption. On the one hand, we formed an incubator with the idea that creating jobs is a great way to resolve poverty. It sounds very simple, but it's much harder to do. And Pittsburgh has a particular issue is that we don't have a lot of place for very early companies, just above angel investors, to try out their ideas in a place where they can afford the rent. So here's a hospital. It's owned by a non-for-profit conglomerate. We're an integrated system. And I convinced the CEO of the system and of Highmark. Starts with, I have this crazy idea. So we formed a partnership with an incubator that's supported by the state of Pennsylvania. We threw in half the money, they threw in half the money, and we started renovating it, but not at hospital rates. We're renovating it Jeff Cohen rates, which are really cheap. So we can paint things, and what you find is that the people in that community, this is really their asset. So the repairs that they make to the hospital in terms of painting and carpeting, they're very inexpensive. Number two is hospitals have great bones, and probably the most important bones in the hospital are the HVAC systems. So the recirculation and the filtration makes it amenable for any kind of a BSL-1, BSL-2 type of lab. So our ability to convert an old ICU into a 10,000 square foot incubator space, and we're doing it about $150 a foot. The second part of this is that disruption hits communities, and you have assets implicit in hospitals, like kitchens and lots of space. So we went down the path of working on social determinants of health, specifically food and education. We have a school district, Northgate, which is relatively poor. And how do we affect changes in the population? So we started measuring, before you were talking about data, we found that healthcare charges are surrogate markers for the performance of a population. And you can follow these because they directly correlate to the PMPM that the insurance companies measure. And we were able to demonstrate that by feeding people, this is a novel concept, by feeding people, you can decrease the PMPM of a Medicaid population, and you can also decrease the number of times they come to the emergency room. So if you want your hospitals to survive, you got to keep the poor healthy, which is completely different than what we've done before. But I approach this through an economic lens through healthcare, not through the social justice lens. And I'm not saying that I'm right or somebody else is wrong. It's just it's really hard to get things done. And what we want to show is that we can give people a chance to achieve what they want in life by doing basic things like feeding them, finding them housing, educating them. And that's our approach to this problem. So it's a little bit different, which anyone that knows me knows that that would be typical of how I would go about it. But it's actually showing real signs of success. So I'll stop there, Michael.
Yeah, that's great. Thanks a lot, Doc. I mean, I want to talk so much more about this, and I think what we're going to do is set up a longer interview where people can join and talk more about this in detail, specifically the work that you're doing at that hospital system. I'm going to give you one question just very briefly, and then I'm going to hand off to Dr. John Dayton, who will be joining us as our Dr. Moderator. How replicable do you think this is versus how you mentioned you were getting Jeff Cohen rates on your renovations. So could we be doing this in other low-income neighborhoods, or is this something that's only specific to you?
No, as we started this program, the key to this was it had to be scalable. Mm-hmm. So the people in the building that do the labor are actually paid for by the system because they're repairing an asset that's for the hospital. So there's no additional cost at that. Number two is hospitals that close are in poor neighborhoods, so you got a great place to start. If you look around, you'll find that there's a kitchen in there that used to serve 1,000 meals a day. So, can you come up with a sustainable way of feeding the neighborhood that's poor and following their healthcare charges, which we do through DHS? The whole purpose of this, and when people ask me what I'm doing, it depends upon the people, but I want to change the healthcare system before I retire. And when you look at this, the future state of healthcare is that the provider systems are really social service agencies that occasionally operate on people. So you've got to get in front of the problem. And these social determinants are not just cute things that are toss out phrases and buzzwords. They are real factors that you can affect and follow them through the lens of a charge system within a healthcare provider network.
Excellent. So thank you very much. So let's one of our items right there is to see if we can scale your innovative system right now that you're doing out there into multiple neighborhoods across the country. That would be one thing. Dr. Dayton, what do you think of that as a potential solution?
Let me make sure my
we can hear you. There you are.
Stream close up. I think that's a fascinating idea. What I love to see is different ideas coming out of different spaces, and ultimately the goal is, all right, which of these things can we measure? And as you mentioned, where can we replicate this? I mean, Pittsburgh is not the only area that deals with these kind of problems, and so it'd be very interesting to see what kind of things can we export out of Allegheny Health that will be useful in other areas.
Right. What types of experiences have you had with the kind of decay of a healthcare system matching the decay of a community? Have you seen that yourself?
Yeah, it's interesting. I spent the last couple of years working on the Navajo reservation. So on one hand, that's a very austere environment. There's low dollars spent, but at the same time, they're able to coordinate a lot of things that work really well. For example, during COVID, the cafeteria in the hospital shut down, and people are using that space to make gowns because we were basically working in spacesuits for months at a time, and that took priority over another thing. And so it's just a matter of cost shifting and space shifting and realigning what we're using different things for. I mean, that's a simplistic example, but at the same time, that made a big difference to the patients. Another interesting thing is to see what kind of technology can we use outside of, I'm based in the emergency department. So a lot of this is based on how do we coordinate this care better between the emergency departments and the primary care offices. Luckily in the Indian Health Services, everything is matched, and we have ability to see the patient records, whether we're on the ER side or whether we're on the primary care side, and then that extends to psychiatric and dental records. That's not a universal thing. So how do we make these records portable? How are we using tools outside of the hospital? For example, during COVID, folks there was only so many beds, and then our ability to admit patients got limited by the available beds and surrounding facilities. And so it became an issue of, all right, what's going to be the best thing for this patient in this community? This patient can go home, but they need an oxygen monitor. This patient could go home, they need oxygen, but do they have the facilities? A lot of these folks don't have power. 30% of them didn't have power to plug in an oxygen concentrator. So there are a lot of tools that were managed, but we tried to really coordinate the emergency care with the local primary care, with the surrounding facilities in Phoenix and Flagstaff to kind of facilitate the best thing. But as you mentioned, one of our big things is, hey, we need data, and we need to communicate. We need to use tools outside of the hospital. The physicians that are involved need to be able to monitor those results for those patients, and we need to be able to share that information.
Excellent. So I think that's a great time for us to transition with our panel as well and bring them on. So we have Dr. Cohen's solution, which is really great and potentially scalable. We have John's input that there are other solutions outside the system that we need to be able to engage with that. And with that, I'm going to be bringing on our excellent panel of speakers. I'm going to start with Dave Ochi. And the reason I'm going to do that is because he runs the Innovation Hub at CSU Domingo Hills. And one of their mandates is actually to integrate the community itself in their innovation center so that they can try to deal with innovation in the community as a paired event. David, what would you say about the solutions provided so far? What has your experience been? And what are the difficulties in trying to engage the community to do these types of things?
Well, first of all, thanks for having me, and it's great to be a part of such an esteemed panel. Jeffrey, I have to tell you, I've been a fan of the work you've been doing, and coming from an entrepreneur background, we're very used to just painting the walls ourselves, and working off of folding tables and stacked boxes as our seats, right? So, and that's not what we think of when we think of funded medical device companies with $150 million Series Bs, this kind of thing. And it just is it's a different world. And then the thing I would say to answer your question, Michael, is that we have to look at this as something that is an entire massive ecosystem. And I love the fact that Jeffrey's trying to change healthcare, right? I mean, what an ambition. And luckily we've only got another 40 years of his career in him to try to accomplish it. Right. And that time frame that we are talking about, whatever measure you want to use, a sixth of the nation's economy. This is going to be a ship to turn. And one of the things that I frequently see is that there's a lot of thought about innovation in healthcare as being devices, therapeutics, diagnostics, whatever it is. Right. It's always about the treatments, and there's just not as much talk about innovating the process of healthcare. The systems are built around efficiency and excellence, right? And all the measures are around that. And yet, if you look at how startups and innovation really takes place, it's messy. And we don't like messy in the healthcare space, right? It has to be clean and perfect and precise and replicatable and duplicated exactly the way it is. Otherwise, literally, you can lose your license. You screw up once and your career is over, right? And so there's the culture of innovation, I think, is probably the biggest driver, that we have to find a way to make it so that we accept diversity of environments as testing grounds and labs for us to reasonably play in, and that what we do in Pittsburgh may not be what we do at Stanford, may not be what we do in LA, and that by allowing each ecosystem and group to experiment towards excellence and innovate, we're going to find the best practices. If we all do the exact same thing everywhere, it's your argument for we've created equity, but we haven't created innovation out of it. And so we have to find this path that we're on a path towards equitable solutions, but not necessarily having to accept that innovation needs that messy playground to work in. And so I think the biggest one is just getting a culture of innovation. And then the other thing that was brought up in the last panel that I think is very true, when you get into some populations that have come from disadvantaged backgrounds, trust is the biggest issue. There's a huge amount of systemic distrust that we have to spend time unwinding.
That's a great point also. Thank you. I'm going to introduce our last two panelists right now. We are waiting for one more who had a little bit of technical issues. Hopefully he'll join us shortly. But when we're talking about regional ecosystems and different types of ecosystems to play with, well, here we have two members of the Utah ecosystem. So Will Walker comes from Hall Venture Partners, where they're operating out of an opportunity zone in Provo, Utah. Is that right, Will? Provo?
Yeah, that's right.
Right. And Chandana represents Altitude Labs, and she represents a stacked partnerships with a number of innovative organizations and all the work that they're doing also in Utah in order to provide wet lab space and innovation support in their area. So with that, actually, I'm going to start with Will, and then I'm going to hand off to John to moderate from here on out. Will, what do you think about the differences between different areas and different solutions that are provided therein?
Well, I've heard so many interesting things that feed into our 130-acre campus in an opportunity zone in Provo, Utah, because literally our 70-year track record on um, innovation and social impact and ESG for 70 years. Tangible technology is kind of acknowledged as a leader. We're kind of the poster child for HUD and for EIG and some other, government and non-government think tanks for not only opportunity zones, but for redevelopment in hard hit areas. And, it all comes down at some point. I've heard a lot of things about jobs. I think Dr. Cohen and David both mentioned it, education and jobs and trust and all of these factors go into our 70-year history of what we've done. And collaboration too. David was starting to, really did a good job at some of the ingredients that I've spotted over my long private equity career. I'm on the money side, but also transactions and profits have to go in at some point to create the jobs and sustain the jobs. But the collaboration we've already had with ASU, Texas A&M, UCI, UCLA, UMass, I could go on and on. It's not just educational institutions that want to copy or joint venture, because our campus, our innovative campus, is right on the BYU, next to the BYU campus. It's 130 acres. We turned, and this is a Pittsburgh reference, we turned an old steel mill, which was the largest employer west of the Mississippi for many years, and it went into absolute total decay. And we've turned that old steel mill into employing 750 people now, 200 of them scientists, engineers, and medical talent, healthcare talent, with our own patent office on there and other shared resource systems. So that's why we really enjoy invigorated collaboration, we call it, because sharing material communication, what's working, what's not, even resources, whether it be in a healthcare project or it be in an ESG project, because we do everything from electric vehicles to, AI toilets. One of your last panels had a big deal about an ounce of prevention is worth a pound of cure, with so many people coming in from lower income neighborhoods say, well, diabetes is part of my family. There's no way I can do anything about it. But, once again, in healthcare, we're a leader in preventative, identifying healthcare and doing something about it through education and collaboration. So anyway, that's my little intro there, and I had something with steel and collaboration and all of the above. So I'll get it back to you.
Way to hit the wheel on that one. Very good. So Chandana, talking about collaboration as a way to like bringing these different groups together. I mean, it's not easy when you're trying to play the system and pull like these disparate points of view and get them to focus together. What has your experience been on that front?
So, we're, as you kind of alluded to, Mike, Altitude Lab, we are co-founded by Recursion Pharma, which has completely changed the way they pursue drug discovery using a data science platform, and the University of Utah, which is a powerhouse here for life science IP. And what we found through collaborating and bringing all these minds together is that our teams have all these experts around them to guide them about problem solving from different lenses and points of view. In life science, we tend to find a discovery and then try to fit, a square peg in a round hole and figure out which one will wiggle in enough to like make a solution of it. And what I love about what Jeff's doing and what I'm seeing some of my teams do now is actually by immersing themselves in the clinical environment, finding the problem space, and then finding the path to solution. And that really can only happen through collaborative relationships, right? So whether you build a collaborative relationship with a hospital network or a clinician, or you can get to a reservation like John gets to do now and then and see like the real problems that people and patients are going through, right? So one of our companies has done that. They took the human-centered design from IDEO, that model of doing hundreds of interviews, and they were able to figure out by just simply reformulating a simple painkiller that they can deploy that for 1/10 of the cost of the current painkiller methods that are used in post-operative pain management, And now that solution not only addresses the poorest and helps them get relief, but is cost savings for the 1%. So it's, there's so much opportunity through collaborative relationships and taking on new methods of design thinking to help the entire value chain and the entire population from the ground up. Anyways, wrapped all those ideas into one, but I love what you're doing, Jeff. I went to Carnegie Mellon and my first research projects were at Allegheny General Hospital. So like, I know exactly what you're talking about. Yeah, love it.
It's so great to have people from different spaces and also experts on collaboration. I'd love to hear more about unique things that each of you are doing. We got a little bit of a taste of it with Jeff's background, obviously things that Will and Chandana and David are working on. But I'd love to know one of the big things that that we see is if something works somewhere, it obviously isn't going to work in other places. But do you guys have ways of spreading good news or good projects that you've done individually? For example, let's say you have a pilot, it works great. How do you get that news out, or how do you export that to other areas? Let's kind of take everybody one by one. If we could go, Dr. Cohen, Will, Chandana, and David.
So how do you let people know that you're doing something that makes a difference? On the innovation side, go make some money. People tend to follow that, and there's nothing wrong with making money. But a comment about making money is that crisis leads to innovation, and innovation eventually will be satisfied, and then you end up with a period of creative destruction. So what we saw in many episodes for the steel mills was the creative destruction of an industry that rebuilt the world after World War II. I look at healthcare today and I see the same process. And are we going to end up being Kodak, or are we going to end up reinventing ourselves like some of the companies are today that are legacy industries like IBM? But the innovators, the people that actually do the innovating, are not people that build devices or make drugs. The innovators are a real pain in the ass. They're the people they have an idea and they have the personality structure that they're just going to go do it. And they really don't give a damn what anybody else thinks until they prove themselves wrong. And they're the 1% of the population, the ADD kid that would nobody go away, leave me alone. But yet Durrell was one of those kids that I introduced to Mike Szymanski. It took about 5 to 10 minutes to figure out who he is. Look for the people that are different, okay? And how to solve a real problem. That's how you let people know.
It's such a great point, and it's nice to see that Allegheny recognizes your value, and even though you may be saying things that will cause disruption, it's a positive disruption. Some academic institutions are very hostile toward that. If you have a side hustle, if you're building something else, they want to control the IP, or they want to tell you that you can't do that because all of your attention should be focused on the institution. Has Allegheny? What's the environment like there? Do they have separate rules for entrepreneurs, or have you had trouble navigating that at all?
So institutionally, first of all, I'm not of the belief that the institutions promote innovation or change. They're the last meeting of the Dinosaurs Club where they all voted against extinction. So the innovation has to come from outside. It doesn't mean it won't come from inside, but it has to come, which is why we did this deal with an external incubator to bring in startup companies from CMU, Pitt, and other areas around Pittsburgh to bring me your ideas, and that I'm the connector to the clinical world or the voice of the customer. That being said, I can't imagine having to put up with me for 35 years, but I give them credit for at least allowing some differences of that 1% different person to be able to go out and make a difference. And a big shout out to David Holmberg and Cindy Endorphian, who were my two bosses. They're really great people to allow this to happen. So if you're going to do this in an institution, find out somebody that has a lot of patience.
All right, with that, perfect transition to bring in our last panelist here. Sorry, we were having technical problems even getting him on, but it was actually not on his end. It was on ours, I'm finding out. But Joseph Spence works with he founded Justice Capital, and he's working on a tremendous number of projects that actually integrate with public-private partnerships and the government in order to pursue health equity in different spaces. And he's an expert on the impact that that has had on local ecosystems in terms of the socioeconomic policies. Joseph, I think one of the trends we just heard about was the difficulty to get institutions to innovate. What has your experience been in trying to get people off the ball when you're talking about the largest institution in America, the government? And what are the valuable things that they've been able to actually contribute, or what have you had to do in order to get them to see the light, so to speak?
Oh, you say that like if it's as if it's past tense. Have they seen it? Is a wonderful question to, I guess we'll find out. But I would say this, in respect to the comments previously, someone has to care enough and be creative enough and calm enough to sit in the middle of the pocket, so to speak, until they figure it out and push it through. All environments have a tremendous amount of incentives all across the board, different people with different motives and why they're doing things. And particularly for innovators whose main motive isn't a 9-to-5 or that type of disposition, one has to be patient and one has to be smooth, to be able to talk to people and understand people, what their motive is, what gets them to move, and to be able to, I don't say push that button, but align with them to get things done. I think in my case, my driving passion, certainly, healthcare is part of it, but I think we had talked previously, I focus a tremendous amount on smart, sustainable cities that work for everyone. And healthcare is a key element to that when you're thinking about what a sustainable, vibrant, abundant community would look like. That's a key element to it. And so that vision, that consuming vision, has pushed me to be able to pull together a number of different parties that maybe would not have seen themselves to have been allies in particular areas, but when they understand the underlying connection between these different things in education, right, housing, healthcare, workforce development, right, transportation, all these things impact one another when done appropriately. And then you can really begin to think about ways to layer in different ways to create returns, right? So it doesn't have to all be a philanthropic focus. If you really want to get something to scale, you have to be able to get more capital to it. And so certainly philanthropy and grants and government involvement has its place to incentivize things. But if it's structured appropriately, you can make a win-win-win for all the people at the table. And that's where I think the beauty and the artistry comes in there, right? Because like I said, you're dealing with different motives. And so that conversation is going to impact different people. My background coming here, before I got in, I retired from Goldman about 4 years ago. And at that time, I was managing the tech, media, and telecom team and the real estate, gaming, and lodging team for the Americas and EMEA region on the debt side of the house. And so that naturally led to me in looking at global things around climate change to understand the integration of technology and land development and how that impacts all these different issues, and how if you're smart about it, you can really build resilient, healthy cities that accomplish all these different objectives. And like I said, healthcare and food quality, as Jeffrey was making his comment, is huge. And so, and just in the, I know we're talking a lot within the U.S. I work directly in a number of different communities here in the U.S. and looking at public-private partnership arrangements with local and federal government. But this is also a dialogue that is an international one, just coming out of COP. They've caught the same bug around the same type of interlinked understanding about how healthcare and how all these other issues blend together to kind of create a resilient, healthy community. And this also came out of Jordan, was there about three weeks ago for the Arab Future Summit there. And same thing, same conversation. These methodologies and modalities of thinking about healthcare and understanding the interlinkages of that with these other issues is a huge topic of interest there. So, but let me just stop there. There may be questions and whatnot. I know other questions that you might want to ask.
It's a fascinating background, and it's great to get that knowledge from different areas. We're talking about how all these things involve having different partnerships and having different focus. Chandana and David, particularly, you guys straddle different areas where Chandana is working with University of Utah and has a bunch of investors and also has lab space. David, you're leading the efforts at your university. I'd love to get tips for other folks who are in academia or in areas where they're trying to make a difference and want to have collaboration and tips for moving the ball forward.
You know, there's one point I would add just on that there as an example. Right before the pandemic happened, I had got the royal family of Norway to come out to Utah, and we did a wonderful event. We did a broadcast into the school system with Princess Martha talking, again, smart, sustainable cities that work for everyone. And we did a number of other events, a women leadership focused event at Modern West Art Gallery and a few other events. They have been a wonderful partner. They got a lot of their money from oil, right? They've made a huge pivot to focus on sustainability focused themes. But I found both them and a lot of the other Middle Eastern sovereign wealth funds, if you articulate, and even within the US, right, if you articulate the value proposition to them appropriately, they are more than willing to engage. And like I said, especially in healthcare, I mean, it's a huge sector of the economy, clearly, and it's not functioning right. But I think it's ripe for disruption in a lot of areas. And so getting a lot of folk like that to be partners, and then looking at other service delivery organizations, like in our case, federally qualified healthcare centers have been very wonderful partners with a lot of the work that we do. And so the field is very ripe, I think, for disruption and for non-traditional players to get involved.
There's huge value in finding something that's worked somewhere else and say, how do we export this and how do we work together and who are those players? How do we make that happen? Yeah, and Chandana and David, I'd love to hear tips you have as well, and then we'll.
Sure. For all of our academics out there, or if you're, faculty / physician, moonlighting in the lab, an interesting thing that a friend of mine and I were thinking about the other day was that there is more available SBIR funding out there than there are R01s. And I think that, let that sink in for a second. So an SBIR is funding to go start something and commercialize a technology. So if you are, moonlighting in the lab still and thinking about, hey, how do I make meaningful change and impact the lives of millions of patients? There's nothing like innovation to really tap that. And there's money to do it. And post-COVID, I mean, as we slowly build towards a post-COVID world, we're blessed with an environment right now that every layperson understands the critical value of healthcare right now. And so there's never been a bigger tailwind to go do this. And so if, tips for you is that, hey, it's way easier to make a difference as a innovator right now. And we're in a particularly unique point in time. It's way easier to get the funding, to get the resources, to get the partnerships you need to go and get off the ground and do this than has ever been in my, albeit biased perspective.
It's a great point. And particularly not just the SBIR grants, but there's a lot of funding right now for healthcare innovation. This is a perfect time to take advantage of that opportunity to build out your idea, to scale it, to get some data, to see where it can work somewhere else.
I echo that. I think there's a few things that come to mind. One is that we think of innovators as a person or a type of group of people that sits off in some corner, or they're over there at the innovation lab, or this kind of. That's defeating the purpose of an innovative culture. I think one of the keys and one of the things I'm pushing very hard on at Dominguez Hills is that every single person on campus is an innovator, and they all have access to problems that we need to solve in ways that we could never understand them. They are the group for us to go find problems and solutions from, right? And we spend millions of dollars every year all around the country doing I-Core study to do end user assessments of things. Yeah, and we've got, on our campus, we've got 17,000 students that not necessarily in the medical space, but they have insights into their own lives. We have to culturally find ways to extract and pull all that data from them so that we start helping people on campus, staff, faculty, students, everyone think of themselves as innovators. Because if you want a skill going into the career of the 21st century, it's be a really good innovator who can get things done. You mix those two things together and you will have a career that no one could have ever mapped. The other thing I'll throw in is, it was a great point brought up about SBIRs, but one of the things that's most fascinating to me is many universities tout how much research they do and how much federal dollars they've attained. And most of it's federal. They obviously have some corporate contracts and other state grants and things like that. But the bulk is going after NIH funds and, NSF funds, every department you can name, pick your acronym. But the total research budget, and this data is maybe a few years old at this point, but is somewhere in the $150 billion range. Now, I know that went up a lot because of COVID, but pre-COVID, we were talking roughly $150 billion that everyone's chomping for. You've got every R1 university chomping to get those $150 billion. And is there more available than? Yep. But what's amazing is the top 10 publicly traded companies in the world spend that much on R&D. Just the top 10. So we have universities hyper-focused on federal dollars, and yet what they end up creating is innovation looking for a problem. And that's why we have things like iCore, right? And then you flip it around and you say, but look what Amazon and Volkswagen and all these companies, they're spending, just the top 10 are spending as much as our entire federal government. They're trying to solve problems and get it into the market, right? They're going from a problem approach. And that's why, frankly, private companies tend to innovate much better than research-based stuff coming out of universities. Universities are doing a push approach frequently and trying to make the pull come along when they've got an invention. So I think one of the biggest things is for us to allow for that randomness that comes from exploring things and seeing what we can do with inventions and allowing everyone to become an innovator and an inventor, and that be an expectation of the culture, because it's that private ownership, even if it's just yourself as an employee in a company or in a university or whatever, that will drive innovative thoughts that no one had thought of, and it creates the real value in the end. And so I think we can't take a top-down approach to innovation. It struggles a lot. I think we have to let a bottom-up approach come about, and I think that's going to require huge cultural shifts that I'll be along with Jeffrey he's going to try to innovate and completely change the healthcare system. I want to completely change the innovative culture of every company in the world. So
yeah, as long as we all
can I jump in there real quick?
Yeah, please, Will. And then I'm gonna have to wrap us. I'm sorry.
Yeah, I just want to make a few points. By the way, Joseph Spence, you're going to get my vote in the next election, because everything you got it. Everything we've done for 70 years in our Utah incubator accelerator is built from smart cities, smart homes, smart transportation, smart healthcare, and we've talked the talk, but we've walked the walk all the way down the road to profits, transactions, and big time solutions, and all of these ESG, social impact, now the hot buzzwords. And that's why we get so many people like our keynote today with Tobin Arthur, Matt Patsky, to invest in us and also help us innovate from his point of view, which is really ESG and social impact mandated. But it also comes down to profits. And the word I believe we've mended between different universities and different alumni associations around the country that we incorporate, for lack of a better description, is a blend. It's a blend of innovative talent coming out of the universities. We get more MBA engineers in the Utah area than any place else in the country, but it's not just engineering, it's science, it's healthcare professionals, it's all sorts of things, but there's always a blend between new and old, and then the profits, the transactions and sustainable traits that come from these innovative, needed, necessary things. And that's the incentive that keeps the carrot going forward and keeps the innovation productive, sustainable, and ready to go. So I just want to get that in there. I know we're running short on time, but
yeah, I'm really sorry. The reality is that if we were able to cover these topics the way I really want to, the event would be 8 hours long, not 3.5. So there's just not enough time. But everyone that likes this content, stay tuned, because this is just one part of a continuing conversation. This is the third roundtable that we've held on the subject. The fourth are going to be more solutions based. But given where we are and the topics that we're covering, we may end up having almost call it a breakout session or an offsite where we spend a little more time digging deeper into these issues. I'm going to throw out a suggestion that is extremely self-serving from an AngelMD standpoint, because it seems like everybody here kept focusing on this aspect that the types of innovation required in order to solve these problems aren't necessarily startups or technology based, but rather institutional based and communication based and partnership based. And this aspect of how do we connect grant dollars that are trying to solve these problems from the socioeconomic side with the innovators that are willing to put those dollars to work in great ways, like Dr. Cohen has out with the Allegheny Health Network. And it seems to me that what's really needed is, I don't know, a partnership that somehow breaks down the barriers between different stakeholders in the healthcare ecosystem, like maybe an impact partnership, as it were, if I'm just going to coin a phrase here on the fly. But these types of things are exactly what we need to do, and we're going to try to draw on all of your resources to provide more content of this for our startups and our innovators and our organizational people on an ongoing basis. So thank you so much for joining us today. And with that, we're going to have to transition to our next panel. John, I know I didn't give you as much chance to talk because we had some very cool ideas going on there, and I needed to transition quickly between them. But we'll have you back too. So
it's an honor to be in the same virtual room with such great thinkers.